Welcome to the deep dive. Today we're stepping into a really vital area of nursing, caring for medically fragile children, and importantly, their families too.
It's definitely demanding work, but also incredibly rewarding.
Right. And this deep dive is crucial, I think, especially for those of you heading into pediatric nursing. You need this foundation.
Exactly. We're aiming to pull out the core knowledge, the clinical priorities, the key nursing interventions you'll need from the source material.
Yeah.
It's about moving beyond just reading about it.
Okay, so let's start with the basics.
hmm
Who exactly are we talking about when we say children with special health care needs? What's the scope here?
Well, the standard definition comes from the Maternal Child Health Bureau. It covers children who have or are actually at risk for a chronic condition, physical, developmental, behavioral, emotional. That means they need services beyond what typical kids require.
And the numbers are pretty significant, aren't they?
They really are. The data suggests it's around 20% of children in the U.S. So think about that. That's 1 in every 5 families dealing with these challenges every day.
Wow, 1 in 5. That immediately highlights the nurse's role, doesn't it? Not just giving care directly, but acting as an advocate, a case manager.
Absolutely central roles. And just so we're all on the same page, the text really grounds this in understanding a few key terms: chronic illness, developmental delay or disability, palliative care, respite care, and terminal illness. These are sort of the building blocks.
Got it. Okay, let's dive into the impact. Section 1 really focuses on how these conditions affect the child development. What's the main challenge running through all the developmental stages?
I'd say the common thread is this disruption of normal developmental tasks. It's about losing control or having progress constantly interrupted by medical needs or dependency.
So, starting with infants.
Yeah, for an infant, think about trust versus mistrust. Frequent hospitalizations, maybe painful procedures, separation from parents. It really interferes with building that secure attachment. Plus, if their sensor motor exploration gets limited, if they're confined or hooked up to things.
And then they become toddlers. And that's all about autonomy, isn't it? The me-do-it stage.
Exactly. But if they're highly dependent on others for basic needs, or if their motor skills are delayed because they haven't had the chance to, run around and explore safely, developing that sense of autonomy becomes really difficult. Language can also be delayed.
Moving on to the preschooler.
Hmm.
This is where initiative comes in, but also that magical thinking.
Right, and that magical thinking can be a double-edged sword. They might struggle with socializing if they feel different or are often out of preschool, but worse, they might think their illness is somehow their fault, like a punishment for something they did or thought. That guilt can be heavy.
Oh, that's tough. Then school-age children. They're supposed to be developing a sense of industry competence.
But missing school, not being able to keep up physically in activities or sports, it really hinders that. They can feel less capable than their peers, which impacts friendships and self-esteem.
And adolescence.
Mm.
It just sounds like a perfect storm.
It really can be. Adolescents are striving for identity, for independence. But needing ongoing medical care, relying on parents, it flies right in the face of that. So you might see some risk-taking behaviors or maybe poor compliance with treatment. Sometimes it's their way of trying to feel normal or exert some control.
That transition makes sense. Now let's shift focus a bit to the family. The text talks about this profound emotional impact, the loss of the perfect child dream, leading to something called chronic sorrow.
Yes, chronic sorrow is a key concept. It's not like typical grief that resolves. It's this ongoing sadness that can fade but then resurfaces maybe at developmental milestones the child isn't meeting or during illness exacerbations. It lasts for years, even decades.
And the day-to-day stressors must be immense.
Unrelenting is a good word. You've got potentially adapting your home, dealing with constant sleep interruptions if there's nighttime care, managing complex medical technology, plus financial strain. Maybe one parent has to stop working and just losing that ability to do spontaneous family things.
The caregiving burden itself sounds huge.
It is. And the source notes that mothers often carry the larger share, which puts them at a higher risk for depression. It's a significant factor we need to assess for.
And this intense, prolonged stress can sometimes lead to a specific issue nurses need to spot: vulnerable child syndrome, or VCS.
Right. VCS happens when parents have been through a really scary time with the child, maybe extreme prematurity, a complex birth defect, a severe illness early on. Even after the child is medically stable, the parents continue to see them as extremely fragile.
So what does that look like in practice?
It often means overprotection, excessive anxiety about minor symptoms, seeking healthcare constantly when it's not really needed, and interestingly, it can lead to real difficulty setting limits or discipline.
Because they're afraid of upsetting the fragile child.
Exactly. But kids need boundaries for healthy development. So the nurse's role might involve gently helping parents see the child's strengths and encouraging age-appropriate expectations and discipline. It's about finding that balance.
That's a delicate conversation, and we shouldn't forget the siblings either.
Definitely not. They often get less parent time and attention, and their own emotional responses, maybe jealousy, resentment, anxiety, or even protectiveness, are tied up in how the whole family, especially the parents, are coping.
Okay, so understanding this huge burden is one thing. How do nurses actually provide effective support?
Mm.
The framework recommended is family-centered care.
That's the gold standard. It starts with building trust. The core principles are recognizing the family as the constant in the child's life, making sure they get the information and training they need, providing culturally sensitive care, and ensuring mutual respect. They are partners.
So how does that translate into practical nursing actions? Screening seems important.
Yes, regular screening is key. Using tools like the CAHMI, the Child and Adolescent Health Measurement Initiative, helps systematically assess how the condition is impacting the child and family and identifies unmet needs. It gives you objective data. And a major clinical goal is always promoting care at home whenever possible.
Even with significant technology needs.
Absolutely. Home is almost always the best place developmentally, even for kids needing ventilators or feeding tubes. They tend to do better emotionally, socially, and often physically when they're integrated back into their home environment.
Which makes early discharge planning absolutely critical.
Mm.
This isn't something you start the day before they leave, right?
Not at all. It needs to start almost from admission. You're setting up community supports, teaching the parents the necessary skills. And the text really emphasizes having parents do the care in the hospital. That builds real confidence.
That makes sense. Get them comfortable before the safety net of the hospital is gone.
Right. And coordinating the equipment and supplies is huge. That's a massive stressor for families. Plus, connecting them with financial resources. It's a big logistical piece.
This all falls under the umbrella of care coordination, often within a medical home model, where the nurse is sort of the quarterback.
Exactly. The nurse often develops the written health plan, deals with things like prior authorizations for services or meds, and coordinates communication between all the different players, specialists, therapists, the school, home health agencies. You're the hub.
And it all comes back to that relationship with the parents, recognizing them as the experts on their own child.
Precisely. That partnership is what helps you maximize the child's potential, even with complex needs.
Let's switch gears to a specific group. Former premature infants. What are the long-term things nurses need to be aware of?
Oh, there are quite a few potential long-term issues. Things like chronic lung disease, maybe growth challenges, a higher risk for SIDS initially, hydrocephalus, and unfortunately potential for long-term cognitive or motor delays. They need ongoing surveillance.
But there's one absolutely crucial assessment point for this group.
Yes, and this is non-negotiable, using corrected age. You must adjust for prematurity when assessing both growth and development until the child is about 3 years old.
Can you give us a quick example?
Sure. If you have an infant who is chronologically 6 months old, but they were born 3 months early, at around 28 weeks gestation, you assess their milestones and growth against what you'd expect for a 3-month-old, not a 6-month-old.
That makes a huge difference in interpreting their progress accurately.
A massive difference. And it guides everything your anticipatory guidance too. Like
Yep.
you wouldn't recommend starting solid foods until 6 months corrected age. Nutrition is also key. They often need fortified breast milk or special formulas designed for catch-up growth, and early intervention services are critical.
Okay, another challenge that often comes up with kids with special needs is failure to thrive, or FTT.
Yes, FTT, basically inadequate growth, usually weight gain over time, and children with special healthcare needs are definitely more susceptible.
Why is that? What are the underlying reasons?
Well, sometimes it's difficulty with feeding itself due to oral motor issues or sensory problems. Other times it's related to their underlying condition like chronic lung disease or congenital heart disease, which significantly increase their caloric needs, or maybe severe reflux, GERD.
So assessment needs to be thorough.
Very. You need a detailed diet history, maybe a 3-day food diary. And crucially, observing the feeding interaction between the parent and child. How does the child suck? Is there coordination? What's the dynamic like?
And if they end up needing hospitalization for FTT?
The focus is intense. You'd observe feedings closely, work with dietitians to establish a high-calorie feeding plan, often needing around 120 calc day just to start gaining weight. Strict intake and output monitoring is vital, and providing a lot of support to the parents is key because it's incredibly stressful and anxiety-provoking for them when their child isn't growing.
Right. Let's look beyond the hospital now at the support systems available in the community. There are legal mandates for education, aren't there?
Yes, thankfully. It starts with early intervention, or EI. This is mandated by federal law, the Individuals with Disabilities Education Improvement Act, or IDA Part C. It covers birth up to age 3.
And that results in an IFSP.
Correct. An individualized family service plan. The focus is really on the family's needs and priorities, and services are typically delivered in the child's natural environment, like at home or daycare. It includes service coordination.
Then what happens at age 3?
At 3, the responsibility shifts to the public school system under IDA Part B, which covers ages 3 through 21. The child then gets an individualized education program, or IEP.
And the IEP is developed by a team.
Yes, a team that includes parents, teachers, specialists, and sometimes the school nurse or another healthcare provider. The goal is to provide the necessary supports and services within the least restrictive environment possible, meaning they should be included with non-disabled peers as much as appropriate.
What about financial help? These conditions can be incredibly expensive.
Hugely expensive. There are programs like Supplemental Security Income, SSI, which is a federal cash benefit for children with significant disabilities and limited family income. Qualifying for SSI often automatically qualifies the child for Medicaid, too.
And there's CHIP.
Right, the Children's Health Insurance Program. This helps cover kids in families who earn too much for Medicaid but can't afford private insurance. States administer it, so eligibility varies a bit.
Beyond finances in school, what other supports are vital? The text mentions respite care.
Respite care is essential. It's basically providing temporary relief for the primary caregivers. It could be for a few hours, a weekend. It gives them a break, helps prevent burnout, and allows them to recharge or tend to other family needs. It's crucial for family well-being.
And what about complementary therapies? Families often explore these.
They do, things like pet therapy, music therapy, massage. And the text specifically mentions hippotherapy.
Which is different from just therapeutic horse riding.
Yes, that's an important distinction. Hippotherapy specifically uses the movement of the horse as a treatment strategy by licensed PTs, OTs, or speech therapists to work on functional goals like balance, posture, or sensory integration. It's a clinical intervention. Nurses need to be aware of what families might be using, including herbal remedies, and understand potential benefits and risks.
Okay, one last major transition. Moving into adult care. When does that planning need to start?
Much earlier than many people think. The recommendation is to begin transition planning in mid-adolescence, around age 12 to 14. It's a process, not a single event.
What does that process involve?
Key pieces include helping the adolescent develop self-advocacy and decision-making skills, fostering self-determination. There needs to be a written plan that tracks progress towards adult life goals, addresses things like future housing, employment support, financial planning, and importantly, ensures the teen understands their condition, their treatments, warning signs.
So they're prepared before they actually transfer to an adult healthcare provider.
Exactly. It's about empowering them to manage their own health as much as possible. That final transfer should be smooth, not abrupt.
This brings us, unfortunately, to the most difficult aspect. End-of-life care in pediatrics.
Yes, it's a reality we have to be prepared for. Cancer is actually the leading cause of disease-related death in children over 1 year old. The care remains family-centered and involves a whole multidisciplinary team.
The text mentions a shift in terminology around end-of-life decisions.
Yes, instead of just DNR, do not resuscitate, many institutions are moving towards using terms like allowing natural death, AND. Families sometimes find this language gentler, less like giving up, and more about shifting the focus of care towards comfort when cure isn't possible.
And palliative care in pediatrics has a unique aspect.
It does. Unlike adult hospice, which typically requires stopping curative treatments, pediatric palliative care can often be provided concurrently with treatments aimed at cure or prolonging life. The goal is always maximizing quality of life and relieving suffering, regardless of the disease trajectory. It offers families hope alongside comfort.
So what are the core nursing interventions at the end of life?
Pain and symptom management are absolutely paramount. Pain medication should be given around the clock, proactively, not waiting for the child to be in pain, not PRN. Use age-appropriate pain scales. We limit interventions to those that provide comfort.
And emotional support is obviously huge. How do we tailor that?
It has to be developmentally appropriate. Infants and toddlers primarily need the comfort of familiar people, consistency, physical closeness. Preschoolers might fear death as a punishment, so they need reassurance that it's not their fault.
What about older kids?
School-age children often want honest, specific information. They benefit from feeling some sense of control, so involving them in simple decisions can help. Older adolescents need to be approached more like adults, involved in discussions, listened to carefully, and have their wishes respected. Your calm, honest presence is often the most important thing you can offer the child and the family.
This has been an incredibly comprehensive deep dive. We've covered the developmental impact, the absolute necessity of a family-centered care, critical assessment tools like corrected age for preemies, the importance of care coordination through things like IFSPs and IEPs, and finally, the sensitive approach needed for palliative and end-of-life care.
It really touches every aspect of nursing. And maybe a final thought to leave you with. The source material points out something quite powerful. When a nurse provides comfort and skilled care to the child, it doesn't just help the child. It profoundly strengthens the parent, particularly the mother as well.
That's a really interesting connection.
It is. So think about this. Prioritizing support for the parents, empowering them, building their confidence. That is actually one of the most direct ways you, as a nurse, can strengthen the child and improve their long-term outcome. Supporting the parent is supporting the patient.
A powerful reminder of the interconnectedness of care. Thank you so much for walking us through this complex chapter, and thank you all for joining us on the deep dive.